All right, well, welcome back to Healthy with Nicole. We have a really special guest today, which I'm really excited about. Dr. Tim Syed, who is my surgeon for my explant surgery, and here today to talk about breast implants, breast implant illness, and how it might even be affecting gut health, which is also near and dear to my heart. So thank you so much for your time today, and welcome to my channel.
Thanks, Nicole. It's really an honor and privilege to be here. I really appreciate you thinking of me to join you here on your channel. And, it's really a privilege for us to work with patients in plastic surgery and medicine in general. And also, patients who are kind of, proactive about their own health and who are researching literature and being advocates for themselves and for others. I mean, that's really, that's paying it forward to the rest of the community. And I think it's important that when we have these dialogues that, we try to see what we think we understand, what we think we know from science, what we don't know, and, what are some things that need to be researched and focused on for the future to kind of allow us to be holistic in the way we advocate to patients, what we offer patients. And, obviously the subject of breast implant illness is near and dear to my heart, and is one where I think there is a lot of need for just kind of open exchange between patients and doctors and just the whole ecosystem around breast implants.
Yeah, definitely. I think one of the reasons why I wanted to have you on my channel, for my viewers, they're really here about gut health. That's what I focus on. I had a pretty severe illness of ulcerative colitis for 7 years, which I was able to heal through diet, nutrition, things like that. And I often got questions during that time if people from women who had implants that wanted to know, do you think it's related? And a lot of questions. So I don't know that I had colitis before I actually had the implants, so I don't think it was for me. But one of the reasons why I was so excited to have you on was not only did I have a really great experience with you, and I'll talk about that more, but one of the things that struck me about you, which is why I chose you for my surgeon, was that you really emphasized how important it was, whether the science is saying that there's breast implant illness legitimately or not. It's a matter of how a person feels. And you really can't deny, if you take the implants out and someone feels better, that there's something happening there. So just your acknowledgement of, how women feel and what could be possibly happening, I think is so important. So really happy about that. And I thought maybe we could just you kind of explaining how you got into this work and more about yourself.
Yeah. So, I'm a board certified plastic surgeon, and I'm entering in my 20th year in practice, which sounds crazy, but I just a little bit about my educational background. So I went to Berkeley, majored in basically biomedical engineering, and then went to UCSF for medical school, University of California, San Francisco, and really had a great experience seeing sort of the way surgery can really impact people's lives in a very immediate way. And I had wanted to be a surgeon since I was 12. When I grew up in Salt Lake City, Utah, they had done the research on the artificial heart. And we got to see sort of the labs where all that research had been done, and the idea of sort of engineering technologies to try to help people really interested me. I think and then eventually I decided not to do heart surgery and rather to do plastic surgery, because I found that the balance of the artistic side, kind of the left brain and right brain, both working in balance. There's a lot of creativity in plastic surgery, and every patient is their own unique person. And their own unique canvas, if you will. And, in what we do in plastic surgery, there's a reconstructive component and there's an aesthetic component. So it satisfies my desire to solve problems and also to be kind of creative with my eyes and my hands and so on. And I trained in surgery, general surgery at Massachusetts General Hospital, and then returned to UCSF for my plastic surgery fellowship. I then practiced in South Florida for over a decade, and I was in a large group practice doing a lot of reconstructive surgery. So I did a lot of work with putting implants in for reconstruction for cancer patients, as well as cosmetic augmentation, and then all sorts of revision breast surgery. Of course, did a lot of other, surgery and still do facelift and other things, but, got kind of known for breast work. And then I eventually started working with some other healthcare startups on quality of care and kind of medical informatics and ways we can sort of improve the healthcare system, which eventually had me relocate to San Diego. And then one of the companies I was involved with was actually acquired, which was really cool for us to be part of. And then I started this solo practice, and we very quickly started to get referred patients for BII concerns and for explant surgery. And it really kind of started with one or two index patients who I'm very grateful for, who said to me, you know, if you're going to do this, you better educate yourself. You better take the time to try to understand what these patients are dealing with. What are their concerns? What does the literature say? What are kind of the gaps in the knowledge base here? What are the kind of it's like know your memes, you know, in the internet, like know what the themes are that patients need to hear answers about, and then develop your approach. And, you know, I can't profess to know everything about this phenomenon because it is at times very puzzling. And I think it's obviously controversial in our specialty. But what I have seen, and now that we do several hundred explants every year, and this has become sort of the largest part of my practice, is that there are almost no patients that have come to me concerned about BII symptoms who have gone ahead with explant surgery, who have come back and said that they saw no improvement in their health. Mm-hmm. And we have to temper that by saying that we can't promise any patient before we do the operation what's going to happen, because it's almost like the surgery is a very invasive, you know, diagnostic test.
Right. Yeah.
There's, you know, it'd be great if I could send you for an MRI or a lab panel or a genomic test or something, or a microbiome test or something that would tell us, hey, you know, you have this gene, MTHFR, you know, metabolic gene, or you have this finding anatomically or something that we could say, you know what, this predicts how you're going to react if you have breast implants in your body. We don't have that kind of level of analysis and cause and effect understanding at this point. And so then we have to look at really the outcomes and say, what are the outcomes for these patients? So if you take a step away from this kind of maybe party line in plastic surgery that seems very dismissive of BII patients, and say, let's say we take it that we believe in a phenomenon called breast implant illness. Does it matter? Because if nobody gets any better when you take them out, then are you helping anybody? And when we see that the overwhelming data, not just in my own anecdotal experience, but some of the scientific literature that's being published that I'll go over with you. I mean, it just seems that if you feel sick enough and you have implants and you come forth for explant surgery, statistically, it seems that the overwhelming majority of patients report significant improvements in these kind of life debilitating symptoms in many cases, to where we do feel like we're providing a quality of life improvement, which is really what plastic surgery, if we get down to the nitty gritty, you know, is about.
Right. I've always had the feeling that whatever people want to do that makes them feel better about themselves and improves their life, do it. And there's a lot of stigma around I think plastic surgery, and a lot of opinions about it. And I really I've never been against it. Obviously, I had it myself years ago, and I did I think did help me to feel better about my body, and that was the goal with it, and it did help me. But I think what we're seeing is that people are okay with that, but the sticking point is that they're not getting enough information to make an informed choice. That's what I see is maybe, if they really have the knowledge about the risks and still choose it, then so be it. But I don't know if I would have chosen it if I really knew the risks, because I just didn't really get a feel for that. And I know, and maybe you could talk more about what the risk could potentially be, but I know in 2019, they added a black box warning to breast implants. And I had never heard of that, even after I had my implants. So can you talk a little bit about the, obviously we know why people get implants and the pros is in terms of people feeling better about their body, but what are we needing to know about the risks involved?
Yeah, so I think, what you bring up is very important, which is the concept of informed consent, which is a cornerstone of doing surgery and doing medical care on people, which is that it's your body and it's your choice. And I believe very firmly in that. And, you need to, if you're going to make choices, you need to do that with the best information or the most information that's available. And that doesn't mean necessarily that it should be viewed totally democratic in the sense that that we shouldn't believe that there is such a thing as expertise and and knowledge. I don't ascribe to the notion that everybody can just learn everything independently without sort of any kind of necessarily a technical background in it, and have the same level playing field. And I think because patients expect of us that we are going to give them some information from a position of some level of authority on knowledge base, because there's asymmetry of information. Mm-hmm. But that does not mean that we get to make the decisions for you. I think that we have to make decisions as surgeons, what we're comfortable with. And I think that if you look at the controversies in breast implant illness, it's really that, number one, there are a lot of, there's mixed data around studies that have tried to answer the question, is there a potential cause and effect link between having implants and having, say, autoimmune diagnoses or symptoms that fall in that rheumatologic and autoimmune kind of category? And obviously ulcerative colitis is known to have an autoimmune component, HLA-B27 gene and all that sort of thing. And yet, you've also demonstrated that, through lifestyle changes and, gut health and so on, you can actually alter your body. And, our bodies are part of the earth and in the universe, and we're made of, the same minerals and components that the rest of the universe is made of, and so the notion that nature and natural substances in our body are probably better tolerated in the long term than substances that aren't in high concentration in our body naturally, it seems to make sense. And yet it's hard to find any kind of definitive article that would say that there's a proven link between the implants and BII symptoms. And yet there's clearly some data, even from some of the implant companies themselves in their own studies, that suggested a higher rate of fibromyalgia-like symptoms, and even some autoimmune diagnoses like Sjogren's syndrome, scleroderma, and some other things in post-approval data from the silicone implant trials of the 2000s that led to the resurgence of silicone implants in the US in around 2007. And so to say, for my skeptic colleagues who are on one end of the spectrum of this, is almost like religion and politics, very polarized echo chambers. And, for those who are on one end who feel that there's no such thing as breast implant illness, and who would say that these patients are experiencing a placebo effect from the removal of their implants because they believe that the implants are making them sick and therefore they're manifesting these improvements, I would say that, the implant companies have some of their own data suggesting that maybe there is a higher rate and maybe it's a small increase level. But if you don't know that and you're not given that information ahead of time, then you're not necessarily making an informed choice. And plastic surgeons do give these brochures and pamphlets, and there is a signature page that you're supposed to review that acknowledges you've reviewed the pamphlet, that does talk about the data, that does talk about studies, and even includes language in there where the implant companies say the long-term effects, say, of leaking silicone, or even the presence of implants and the possible association with inflammatory issues is not 100% worked out. Overall, the FDA has this responsibility to say, do we think that in the main, a certain class of medical devices has an acceptably low level of adverse effects to be approvable and to continue to be approved? And they have to revisit that with more data. So the FDA was faced with, a mountain of experience of a lot of women coming forth who've had health problems, who have had improvements in their health when their implants came out. And so they convened meetings in 2019, and, they had representatives of the implant companies, plastic surgery community, patient community, and they basically had to come out with what's a very carefully worded but fact-based statement, which is now part of what they call a boxed warning. So before you put implants now in, you're supposed to have patients review this and sign an acknowledgement. And I think that's a step in the right direction in terms of empowerment and informed consent. That does not mean that necessarily all plastic surgeons who do a lot of augmentations are necessarily putting a lot of emphasis on that language when they do the consultations. I mean, let's face it, we're in the plastic surgery industry because patients seek changes, and I'm talking right now on the cosmetic side, they seek changes to make them feel better about themselves, to improve their perceived quality of life. And I think people should, on the one hand, not be body shamed and should feel that they are beautiful people, however they were made and however they've evolved. And I've certainly tried to, I have a 3-year-old daughter, and I don't use her as a prop, but I do like to bring her up in conversation with my patients by saying that I don't want her to grow up thinking that big breasts are inherently better than small breasts, or, tuberous breasts or saggy breasts are somehow not feminine or not beautiful. nothing makes me angrier than somebody says, well, I don't want to have National Geographic breasts, because I'm like, what does that mean? What are you saying? What does that mean about the people who that's their bodies?
Right.
But I get it. Like, I have things about my body that maybe I would like to see be different. And, and that's human nature. And we've been adorning ourselves, makeup and, and jewelry go back to at least ancient Egypt, ancient India. And so I don't think we should judge people for wanting to have plastic surgery, as long as their goals seem reasonably informed. I think that if their expectations are reasonable and if they understand what the risks are, and that's where this conversation really, I think, is turning in the industry.
Definitely. I think that also you hit a good point. We have a really an intense amount of pressure on as women to look a certain way, especially in in these days. If you dial it back to like the 80s or 70s, even, you didn't see people with implants, breast implants, implants, you just don't see it. And now, and that, I think that was kind of reserved for like movie stars and celebrities. And now everybody has it because it's pretty easy and accessible. But I think we are starting to shift back to like what you said, just kind of accepting people for their bodies. And it really comes down to each person having to accept where they're at. And that's hard in these times. And I think that's what's driven all of this, needs to change. But again, I also don't judge people, but what I think is important is that they know, like you say, what the risks are, and they can weigh it out. And if it's still, if their body bothers them that much, then maybe it's worth the risk for them. If it's causing them a lot of depression or whatever. I could see that.
I mean, there's definitely clear, ample evidence that, if expectations are reasonable and, carefully well performed, aesthetic plastic surgery can have significant quality of life improvements for patients. Who's the judge of that? The patients are the judges, right? I mean, who knows what your quality of life is? You have, obviously people around you can sort of assess if maybe you are being realistic about what life should be like. I think, I don't think anyone should expect that life is perfect and doesn't have its, ups and downs and trials, right? But in for the most part, individual patients know their bodies. I think women are very intuitive about their bodies and their health. I think that's, I think if you just even evolutionarily, like, we need the females of a species to be in tune with that, because that's how humanity survives and thrives and goes on, right? I mean, so I think that what I have seen is, and I've been pretty vocal now in some of our American Society of Plastic Surgeons and other societies in our forums, in kind of internal discussions with other plastic surgeons. There are clearly very strongly held feelings by some of my colleagues who feel that this is social media driven, that there's sort of echo chambers that women who have not found answers for their symptoms can sort of find validation in, and that maybe that allows them to accept a set of evidence that supports what they want to believe, but maybe they are unwilling to accept counterpoints. And yet I say, well, then how is that any different from what you're doing? Because you're not really necessarily accepting their counterpoint, and you're also maybe not accepting the fact that these patients, and this has been published in literature, including a recent study by a colleague of mine, Dr. McGuire, in the Midwest. And, they did a controlled, as best you can, really sort of a controlled trial to try to assess, is the symptom improvement that is seen, is it likely across all patients who have implants, or is it mostly seen in the people who self-identify with breast implant illness? And what about the background levels of things like, microbes or heavy metals and other things in women who don't even have implants at all, as maybe a control group? And what they found is, at 6 months of follow-up, they found that the group that feels sick enough to self-identify as breast implant illness, 94%, I think, was the number of those patients at 6 months, said they had improvement in at least 2 to 3 of their organ systems of severe symptomatology and less frequent symptoms and so on. And the group that did not self-identify as BII, who had implants that were being removed, including capsulectomy, as part of their treatment for other reasons, say capsular contracture, where the capsule is thickened and tightened, or they have the recalled implants that had been demonstrated to increase the risk of a type of lymphoma cancer, or the textured Allergan biocell implants, or just women who are kind of over it. Maybe they're in a different life phase. Maybe they want to be more natural, organic. They don't feel like having these devices is consistent with that, or they have young daughters and they don't want their preteen daughters to believe that implants are necessary to be attractive and to be desirable and to have confidence in their sexuality and what have you. So that middle group their symptoms, they had a rate of symptoms that we would include in this BII group, which is a very broad group, obviously. I mean, I have some of the symptoms, so that's kind of part of where the kind of healthy skepticism should come in. But, that group didn't seem to see as much improvement. And then the group that didn't have implants at all, they had a background level of certain heavy metals like arsenic and other things that seem to be in higher concentration in the women with the BII symptoms. And so it's hard to know exactly what's going on here, because a lot of the patients will have what look to be the expected capsule response to an implant around an intact implant. It could be a saline-filled implant. It doesn't always have to be like a ruptured silicone implant by any means. And yet you see that the patients, if they feel sick enough, they report significant improvements. And that's been published now in a couple of different studies, and presentation by one of my colleagues of a series of 302 of her patients who came in for BII concerns. And she got about half of them to turn in their 1-year questionnaire on their symptoms. And of those half that turned them in, 95% of those had improvement in their health. So we don't know what to make of the other half that didn't answer the homework assignment, but I don't always, write reviews of restaurants, whether good or bad. I mean, sometimes people just don't give you the follow-up. But I think that tells us that there is a quality of life improvement that appears to be experienced with enough chronicity or length of improvement to say that we don't think this is just like a 6-week or 6-month honeymoon phase, to where those patients would say, is it worth it? Like the worth it score on explant surgery seems to be very high. Mm-hmm. And so the skeptics turn and say, well, the fact that the group that feels that they have BII are the group that got the most symptom improvement, then they say, well, maybe that's because they're the ones manifesting that they should get better and therefore they have a placebo effect. But the flip side of that is to argue, if you don't feel sick, why would you expect to feel better, right? Like the group that doesn't feel sick in the first place, that they don't have a lot of improvement in symptoms, it may mean that they just have a baseline background level of symptomatology that can affect people. And certainly, I don't think even the staunchest of BII advocates would say that every woman who has implants, who has migraines because of her implants, or every woman who's gotten diagnosed with Hashimoto's, which she didn't have before she had implants, got it because of her implants. Because it also turns out that the time frame where most women get implants is also around the time frame that a lot of these autoimmune and inflammatory conditions tend to get diagnosed, and they are more common in general in women than in men. So, I don't have all the answers. What I can tell you unequivocally is that the overwhelming, and I mean like 90+% majority of women who come in with BII concerns, if they feel sick enough and they have explant surgery, they almost always report that they feel better.
Yeah.
Now, I can't promise that to an individual patient. So I always tell them, like, this is a bit of a leap of faith. And as you said before, maybe if you're not ready for it, you're not ready for it. And that's also okay. It's a matter of empowerment and choice and informed choice. So if you say, look, doc, I do feel sick, but, I don't know that this isn't necessarily that worse than I would expect as a 40-some-year-old woman with, kids and a stressful life. And I worry that if you take my implants out, aesthetically, I'm going to not like the way that looks. And that's going to cause me quality of life impairment. I tell those patients, then, you know what? Take your time. Maybe it's not right for you right now. And maybe it's not. Maybe if you can live with, the symptomatology that you have, because I don't know for sure that it's going to get better if I take your implants out. I think it probably will based on what I'm seeing, but I can't give you a paper that says it's a guarantee. At the same time, I can tell you that if you naturally have less than a B cup of breast tissue, aesthetically, it might be very jarring to go through explant surgery, even if we do all the things that we offer patients that we, call it like sort of mitigation or damage control, if you want to be cynical about it. But basically, breast lifting, fat grafting, right, other things that may be in our toolkit, that still may not present, even if it's a good result that I would judge and say, this is a good outcome, looks like she had a breast reduction with a good scar, a good shape. Yes, it's not as full, it's not as round, but it is what it is based on what she has anatomically. It might still be tough for some patients. And, I think that has to be an honest part of the dialogue too. So I don't think that we should be in the position to be, convincing or cajoling people into getting explant surgery. Turns out you don't have to, because most patients, if they've done their research out there, they've come to a point where they can have the resolve if they're ready. And if they're not ready, by all means, please take your time. And come to us with questions, and we'll do our best to answer it. Mm-hmm. And there's going to be some unknowns, And that's, some of the risk we live with in life.
As is the way when you get them too. I mean, plastic surgery
Right.
on the front end isn't a guarantee either.
Right.
I wanted to remove my implants, not because I was sick, but because, well, one, I have a teenage daughter, and I was worried about, she was commenting, how her chest was so small and everything. And I thought, I don't want her to feel that way. And that was a big driving factor for me. But the other thing was that I did it as more of a preventative, because I had my implants for about 10 years.
Yeah.
Are the risks going up, do you think, of people having problems in breast implant illness as they get older because of rupture, or what is the risk?
Not necessarily.
Okay.
Yeah. So, I mean, if we look at the data, first of all, there was a long period in the US where silicone implants were not available, right? And that was because of a scare about what we would today probably call breast implant illness around the early 90s, where the older Dow Corning brand of silicone implants, I would say, were not very good devices, and they had a much higher rate of leakage and much more capsular contracture. And I still see patients who come for it today who have those implants in and maybe never got them out previously, and now are coming in. They have these sort of dinosaur eggs, or really calcified hard capsules around the implants. And, so the question that was being looked at in the 90s and early 2000s was trying to assess, is there a causal link between leaking silicone or intact silicone in a gel-filled implant and autoimmune and autoinflammatory conditions? And there obviously was enough data to suggest not really a causal relationship to allow the FDA to say, we feel comfortable bringing back silicone-filled implants. During that time frame, saline-filled implants that have a silicone biopolymer shell were still and remain, on the market. And so we have patients who come in now who have saline-filled implants where the silicone is only the bag, the water balloon bag. So the balloon you would buy and then you would fill with water, or air, that's the shell. And the shell is silicone biopolymer, whether it comes pre-filled with silicone gel or is filled by the surgeon with IV fluid, saline in the operating room. And, even in those studies I was citing to you, over 50% of the women in one study, Dr. Walker's study of 302 patients, she presented that at the 2020, I believe, American Society of Plastic Surgeons panel on breast implant illness. And about of our 302 patients, I think 160 some of them had saline implants. And we see women with these symptom concerns who have saline implants. So it's clearly not a phenomenon just of ruptured or leaking or occult, maybe unknown leakage of silicone implants. Although every week I have, certainly at least a couple of times a month, I have patients who we go in and do explant surgery on, who we discover that one or both of their implants are either sweating, leaking some silicone gel, or are actually ruptured. And they may not have known, or maybe they had an intuition that something wasn't right on one side, but you wouldn't necessarily see from the outside that there was something wrong with the implant. And, with silicone implants, the FDA said there's this possibility of silent leakage that in order to ascertain that, patients should be advised to get an MRI every few years. Like the original recommendation was like at year 3 and then every 2 years after that. And a recent paper was published that suggested that the rate of occult leakage, unknown, like unsuspected leaking implant with silicone is maybe over 10% at 10 years, which is higher than what the general published rates in the studies were of 5 to 6% typically of leakage at that endpoint of those studies. And so it suggests that maybe certainly in the patients who have silicone filled implants that occult leakage is more common than suspected. But you can still get these BII symptoms if you have saline implants. And when I say get the symptoms, again, there's symptoms, there's the presence of implants, and what we're trying to piece together is are they related? And so the FDA, in their carefully worded, boxed warning, basically say some women with implants develop symptoms and that were not present before they had their implants, and sometimes they're severe. And it can happen with saline or silicone implants. And in some cases, when these symptoms improve or resolve when implants are removed and not replaced. That's almost the verbatim way it's expressed. And what that is it's a factual statement that there are women who get better when their implants come out.
Yeah.
Full stop. I mean, there are women who get better when their implants come out. That's not the FDA saying they know exactly why that is. or what it is about the implants, or what it is that's on or in the implants, or if it's the implants at all. Maybe it is a placebo effect. But my personal experience is that, if everybody who came to me in the BII community was, kind of quirky in a way, or, seems to be, just a little, too hyper focused on this, or, is maybe, has an agenda to maybe get implants banned because they just don't believe that they're safe for anybody. And if everybody was like that in my patient population, then maybe I could see this point of view that, okay, well, maybe this is just, if you believe this fervently enough, you're going to believe that you're going to get better, and maybe there is a manifestation, mind body connection kind of aspect to this that is all that explains it. But my patients who come in for explants come from a broad spectrum of personalities, demographics, ages. There are people who've come to me who didn't come in for BII, by the way, came in for explants for other reasons, who have reported back to me that they had unexpected improvements in things like hair loss or rashes, or things where they're like, I didn't even think my implants were making me sick in any way. I just wanted them out because they were hard or whatever,
right.
40-year-old devices. And to me, that's like, you weren't really trying to convince yourself that removal of your implants was going to make you healthier, and yet you feel healthier. If that's a placebo effect in all of these patients, it's a darn powerful one, but maybe there's something else going on here that we just don't understand. And so, there are advocates out there in the research community who say that, a capsule is while it's a biologic reaction, it is a reaction to the presence of a foreign body, and it occurs because the organism is saying, I don't know what this object is and what it's made of, and it certainly isn't made of me. It doesn't have my DNA on it. So let me quarantine it and sequester it just to be safe. And then when microbes get on it, which is our current theory of capsular contracture, is that this biofilm of microbes get on the implant, probably when you put it in through the incision. That's why there's a lot of effort today to, when you put implants in, maybe use a funnel so you don't have to touch the implant with your gloves, and the implant doesn't have to hit the skin on the way in, or making incisions in the fold rather than the nipple to put an implant in, because there's likely less bacteria that you'll encounter when you slide under the breast tissue as opposed to going through breast ducts that communicate through the nipple to the outside world. And so this idea that biofilm and microbes, like the microbiome that you think about with gut health, to kind of connect the dots, that biofilm can be the cause of capsular contracture. That's not just a theory. It's really accepted now in plastic surgery as the likely, explanation for most capsular contractures. Because, if somebody has a ruptured silicone implant, you can expect maybe the body would wall it off further, thicken the barrier because of that. But there are women who have intact saline implants, and 1 year after their augmentation, they get a capsular contracture. And our theory there is it's microbes. And so, if the body will react to microbes in the capsule, if the body will react to certain technologies on the textured surface of some implants that no longer are marketed and turn into lymphoma cancer, well, then maybe we don't know everything there is to know about the interplay between devices made of foreign materials and how it might interact with your flora and how it might interact with your immune system, and how some people might tolerate this forever, and some people might tolerate it for 10 years, and some people may not tolerate it for a year. I have one patient who had an explant done by her prior surgeon, felt better with symptoms, and then decided to go have augmentation again a few years later. And within 6 months of her second augmentation, started feeling sick again. And she came to me then to do an explant on her, and I did. And she said that almost instantaneously she had improvements. And she's like acting as her own control group, that when she has implants in her body just doesn't do well with it. Why is that so anathema to some of my colleagues, that they feel like we have to decamp into these two, polarized echo chambers, like, Fox News and MSNBC? Like, we have to basically say that there's no common ground here. I can't eat gluten, and I do eat gluten, but I can't eat it the same way, or, lactose the same way as I could when I was a kid. I could eat anything I wanted and be rail thin when I was, 18, 20. If you saw a picture of me in my senior year of medical school, was half the man I am today in age and in weight. And so that's an exaggeration. But, my point is that, I could eat anything. My metabolism was different. My ability to repair myself when exposed to things was better. And so is it possible that with chronicity of exposure, is it plausible that maybe you would just repair myself differently, and maybe you do too if you have this foreign object that your body's trying to live with?
Yeah,
I think it's plausible.
I think it's just really great to have the open mind and, not dismiss people's claims. But I have
Yeah,
one last question for you because I know I
sure.
promised 30 minutes, but
Yeah,
because we are always talking about gut health, and I do believe that
yeah,
that is really the cornerstone,
yep,
foreign substances in the body aside, do you
yeah.
know of any connection between implants and damage to the gut microbiome?
I don't know that we have studies right now that are showing that. I know that there's research going on in the Netherlands and other countries looking at just generally microbiome, not just gut microbiome, but skin microbiome as well, and what that might say about these biofilms and exposures when biofilms are in contact with with foreign objects. I don't know necessarily that we I mean, gut health is a completely blossoming science right now. I mean, if you think about when I was in medical school, they were just then learning about the connection of H. pylori, for example, for
Mhm.
peptic ulcer disease. When I was training as a general surgeon at Massachusetts General Hospital, which is one of the oldest teaching hospitals in the country, we were still learning about acid reducing operations that had been done for decades to try to treat ulcer disease. And now you almost never hear of somebody having part of their stomach removed because of ulcers. Most commonly, if they have a duodenal ulcer, they get tested for H. pylori, and if they have that, they take antibiotics for a couple of weeks. They go on Pepto-Bismol, and it cures them. And so, and that's a Nobel Prize winning, theory now of gut, and flora, gut health. So I do know that there's obviously evidence that bacterial translocation occurs more commonly with certain types of foods and with certain immune system predispositions, which is part of ulcerative colitis and Crohn's disease. Is the problem that this translocation occurs and the gut's immune barriers get breached more easily. And so, you're very fortunate that you were able to make these changes and that your body responded to them, because kind of the default expectation for a lot of patients with ulcerative colitis is there's a chance at some point they're going to end up losing their colon and ending up with an ileostomy and having to manage life that way. And I did colectomies as a general surgery resident for patients with UC, and it seemed like a very difficult diagnosis to receive. And the notion 25 years ago that people could maybe regulate their gut flora enough that they could avoid those flare-ups and complications and not have to be on, steroids and aspirin, Roasa and other medications. I mean, I think that's a lot of advancement. So the short answer is we don't know right now, as far as I know in the literature, and I can research it a little bit more for you and see if I come up with anything directly linking gut flora to the BII concerns. But I certainly believe that the final common pathway here is inflammation.
Yeah.
And we know that there is inflammatory diets, and we know that anti-inflammatory approaches. I know people who they go on anti-inflammatory diets and their back pain resolves. And instead of going and potentially having to have physical therapy, or worse, having to have spine surgery, they basically cure their back pain with gut, food changes, dietary modification, and modulation of their microbiome, and that reduces the inflammation in their body, insulin levels, and other things that play a role in that. So that's where I think that the vanguard of the science is going to take us. Is we're going to learn that there's some of these interplays between gut health, skin flora, immune system, and where foreign materials may trigger that, or certain exposures. At the end of the day, and you've maybe heard me say this, and I say this to some patients, and I'll kind of close with it, which is, as an organism, you're from birth, even pre-birth, prenatally, and then the process by which you are born. If you're born through the birth canal, you get exposed to different flora than if you are born by C-section. So they tell parents of babies, like my babies were born by C-section, they might need some B12 supplementation, things like that. So it starts from before you're even born, and then while you're born, and the rest of your life as an organism, you're fending off exposures, and your body's trying to live with what it can tolerate in the world. And some people tolerate pollen, and some people don't. And some people tolerate gluten, and some people don't. And some people can tolerate aluminum in their deodorants, and some people don't. And some people can eat whatever they want and gain no weight, and some people can be cutting their carbs and cutting their calories and are genetically predisposed to being heavier. And there are some things that, we just don't understand about this interplay between nature and nurture. There's one thing is clear is that these implants certainly are foreign objects, and the body knows that they're foreign objects. And I think that what I've learned is to be very open-minded about this possibility that not everybody will tolerate these things the same way as other people. And as long as you're making that as an informed consumer and an informed chooser, decider on your health, then I think we're upholding our oath to not do harm. And I tell my skeptic colleagues who say, well, sometimes you're making patients look worse by taking their implants out. I say, that's a value judgment, isn't it? And I get where you're coming from. But if these patients feel that their quality of life has been improved and they're willing to accept the trade-offs, then they've made an informed choice, and I've helped their quality of life. And I sleep well at night doing explant surgery for that reason.
Yeah, that's great. I love that. Well, thank you so much for all the wisdom you've imparted on us today. I have to say that I had a great experience with you. My recovery was great. I love the results. And I went from a D to a B, a small B. And, it is a major change, but I'm really happy with it. And I encourage women.
And it's your natural you.
It's my natural me. And I'm actually really happy with it. I'm more than I ever thought I would be. So thank you again.
That's great. Well, there's a sign in my other office. I don't think you've been to our San Diego office, but there's a sign there when patients leave, and it says, love yourself. And I think that's really important.
Yeah, absolutely. Well, I'm going to put all of your contact information in the show notes for people that live in the area or not and want to reach out and connect with you about a consultation. But obviously, I highly recommend you. And thank you so much again for taking your time today.
Thanks, Nicole. I really appreciate it. Keep up the good work.
All right. Take care.
Okay, dear. Okay, bye-bye.
Bye.